the different types of HRT that are on offer at the moment? Because we use the umbrella term HRT, hormone replacement therapy, but there are many women going to their doctors right now who are so confused about what kind of HRT that is available to them. How can you help sort of break down what's the best, what's the safest, what's the most effective?
There are so many different types of HRT, and it's a shame because some of the studies that people quote are on a type of HRT that we never use in this country and we wouldn't use, and so it's a bit confusing for people, absolutely. We like to use body identical HRT, hormones that are exactly identical to those made by the woman's body. And in particular, the estrogen is made from soya and then synthesized in the laboratory to make it absolutely exactly the same as estradiol from the ovary. And the progesterone that we like to use is micronized progesterone, which is made from yams, and then again made identical to the body's own progesterone. And that's a sort of very good starting place, really. And then you can have the estrogen orally, or we prefer transdermally. So transdermal can be a gel or a patch. We like transdermal because it doesn't increase the clotting risk at all, and therefore is very, very safe to take, very convenient, very easy to apply, and so on. So that's a very good starting point. Now, not everybody suits those, and then we do start fiddling around and tinkering around the edges with different preparations, but generally that is sort of, and of course you've also got continuous combined HRT and cyclical. So when a woman hasn't completed the menopause and she's still having a cycle, we have to support that with a cyclical type of HRT where she'll take estrogen the whole time and progesterone for about 12 nights of the 12 days of the month. Once we assess, or if she has had no periods for a year, or we think she probably would have gone through that stage if we weren't giving her HRT, then we can change her to continuous combined HRT, and in that case she won't have a bleed anymore. Yeah.
And just to add, I mean, I think the more preparations that we have, then the better, because it's about individualising, and no two women are the same.
Yeah.
And I think some of the problems that we've run into in the past is because we've treated women as if, you know, they should have one type of HRT for one condition for one duration of time, and actually we should be individualising it and choosing from the types of preparations that Tina has talked about. But I would say over the last 20 years or so, we've become, I think, more refined in the way we prescribe our HRT, and this is minimising the side effects and maintaining the benefits, or maximising the benefits for our patients.
I think one of the most common questions we're asked is, how long can I stay on this for? And you know, a lot of people have been told by their GPs or practice nurses, you can only take it for 3 years, or you can only take it for 5 years, or 10 years, and then you must come off it. And we haven't actually got any data. That advice isn't based on any particular data that says it's a good idea to do that. So we like to support women for as long as they would like to take the HRT. We will support them in that, and that's what the NICE guidelines say.
It's what the NICE guidelines and all the other guidelines are saying, that again, it should be individualised, and if a woman continues to have symptoms the whole of her life, then she should be allowed to continue with the hormone therapy. If she wants to try to come off, then we tend to advise bringing down the dose gradually rather than stopping it, because that can lead to rebound symptoms.